I'm Peggy O'Kane, president of NCQA. I founded NCQA 35 years ago. We've made a lot of progress, but as I prepare to leave NCQA, I feel there's unfinished business. That's where this podcast series comes in. I'll be talking with some of healthcare's brightest thinkers, executives, researchers, and innovators working for real change. These conversations are for people who are curious and want to help the U.S. escape bad health outcomes and runaway costs. This is Quality Talks. It's my pleasure to welcome Anna Taylor to the podcast. Anna is Associate Vice President for Population Health and Value-Based Care at MultiCare in Tacoma, Washington. She's one of those magical people that can take a set of technical intersections that are really hard to make work and make them work. She brings a sophistication and a can-do attitude to this, and we need more people like her. Anna, I want to thank you very much for being with us today, and I'm going to make you my ally to tell the story of why digitalization of healthcare is offering us so much potential, and we're trying to create a movement where people really want to do it. The theme of this podcast series is, why isn't healthcare better? For me, having been in this quality seat for over 30 years, part of it is the healthcare delivery system is very fragmented. But I think if you take it down to the patient interaction, very often nobody has in front of them the information they need to do the right thing for the patient. So we get all these dedicated people who've gone through years of training and come with their hearts because that's why they came in the first place, but who lack the wherewithal to get the right thing to happen. We're all victims of this crazy machine we've built, and none of us built it alone, or it would have been better, but we're all putting in our little bricks here and there. And we see quality measurement as it can be just a part of the problem, which is what it feels like to a lot of people today. Or if we kind of rethink it, maybe it can be more part of the solution. And so your assignment today, should you choose to accept it, is to help convince people that the path to the future lies through this digitization.
Yeah, first, thank you, Peggy, for inviting me. It's an honor to be sharing time and space with you. I'm very passionate about, I'm already your ally in quality is the pathway to the future for healthcare. What I do in my day job is figure out how to engineer how we get to success in value-based care. What are the tools, the people, the processes that make us successful in achieving that? And then on the side, you find out the problem is actually getting better data to the decision makers when they're making the decision. And then you go through the history of, okay, how do I get the data to the decision makers? You find out that healthcare is centuries behind in its ability to trade, share, and make that data available. So my moonlighting job is as an interoperability expert because I had to become one to figure out how to solve this problem.
And can you just talk about what we mean by interoperability? It's one of those words that if you're not working on it, your mind shuts off, or there's a question mark in the middle of your head.
Yes, interoperability is the trade of data. Think about it as getting data from one place to another, from the specialist EMR to the primary care physician, helping coordinate the post-surgery wellness of this patient, managing their medication. How do we get all the data needed to do that workflow to our providers and our patients who are making these decisions about the patient and the body and their own body? So really, interoperability is the capability to have a longitudinal patient record, to see real-time data, to make decisions at the point of care.
I think about NCQA's mission, and I often think that it's really about getting people to understand that you need systems, things that are expectations. I know I'm supposed to do it. I know how to do it. I have the data I need to do it, et cetera. For whatever reason, healthcare has been a maverick operation. I was a respiratory therapist long ago. I was on my own. I was a lone ranger, and I was handed a sheet to write down when I checked the ventilator and what the settings were and stuff like that. But nobody took the sheet from me. Nobody looked at what was going on. And it was like, okay. And I noticed doctors were operating independently. There was this great nurse when I was working at UVA, and the doctors were coming in and telling her to do contradictory things. And she just said, okay, everybody stop. This patient is going to get the care that this patient needs and not all the different things you all want to do without having talked to each other. So the roots of this are in that way of thinking of like, I am on my own. I do a great job. Please don't question me. And I don't need to tell anybody else what I've been doing. That's my diagnosis.
I think that's a great diagnosis, and it's not going to get better. It's only getting worse with how our society is maturing and being more independent. We need to build in communication because we're not getting more advanced in conversation. We're getting less advanced in conversation.
Yeah, that's interesting that you say that. I feel that too, honestly.
Yeah.
You mentioned value-based care. We've done a lot of focus groups, and we know patients don't necessarily understand what we're talking about when we say value. There's often a dollar store paradigm for value that people have. So I want you to talk about value-based care and why you would want it as a patient.
As a patient, I want the Nordstrom experience, the top of the line, highest value for my dollar. I'm paying for this. And I want to trust I'm going to walk out of those walls a healthier person or with a plan. To patients, value is a lot of intricacies. In the work I do, value is risk-based contracting, which means the provider is taking on actuarial insurance risk to treat a population. Value-based care from an enterprise perspective can mean many things. As we think about Kaiser models, which are fully capitated risk models, all the way down to if you get this person their flu shots, you're going to get $2 or $5. It doesn't just mean better dollars, better care, better experience, better partnership. It means many things under that value, but traditionally, value-based care has been taking on risk, which traditionally providers don't.
Right. One of the platitudes of people that work in healthcare is to say, we have a broken payment system. If you get paid more for everything that you do, you're going to do more, right? So if I can accomplish getting you well in 5 visits, but I could do it in 2 visits with some in-between support. If I lose money doing it in 2, then I won't do it. So the incentives of the society to have the best care I can get at an affordable cost are the opposite of incentives of the delivery system. So there's another aspect, which is if I can do this in a more expensive way, if I can get a specialist to take care of you for something that your primary care doctor might have taken care of you for, I'll get paid more money because our payment system is towards specialty care, more inpatient care, and so on. I have a friend who's frail and elderly, and she wants to stay in her home, but when she was in the hospital, none of that was possible, and the system didn't provide support to get out of the hospital. There are systems in this world that do that, but ours is not one of them. So anyway, it's a longer story.
It's one many of us are experiencing as even in taking care of parents. And I know the system and what's wrong. And what do you mean my dad can't get an echo for 3 months? He's been in AFib for 3 weeks. This is not how we should be taking care of our patients. And it's not necessarily to the hospital's advantage to get people up and mobile. That's block and tackling patient care. Get them up, get them walking.
Right.
And that's going to help them go home. And that's not always how we're incentivized to work in the fee-for-service world.
Yeah. I remember you talking to me about your father's AFib. Why don't you go through that story? Because I think it illustrates how care could really be better and how the system is still operating as if we were at like 1950. We've got technology that could deliver better results.
Yeah, this is just one use case where devices can record data at the home, but there's a lot we can learn now in the peripherals of care. My dad thinks like an engineer. He has all the gadgets. He has the cardia, he has the blood pressure cuff, the O2, everything you can get that would look like a hospital at home. And when he has an episode, he's able to know how long it's happening. His provider has a plan. Hey, if this happens for so long, that's when you call us. Then you call them and there's no connection to the team answering the phone, or they don't call you back, or the MyChart message doesn't get answered because number one, it takes 3 months to get an appointment. Meanwhile, he sits there and I'm going, okay, I know there's a higher risk. Something's going to happen. And I know if we could get in and make sure that we have these things, we could get a plan on what we're going to do. But that data and information is mainly in my dad's hands, not the provider's hand. They're going to read it from the data portal of that device, but it's not connected to the longitudinal story of, hey, there's a history of AFib and this is what's happening. And we need to figure out what the care plan is forward, but I shouldn't have to wait 3 weeks to get an answer. And then they're just going to send them to the ED, which they didn't have to. I know there's a better way to do this because you can see it in your mind how it can flow. It's just not the culture built into a fee-for-service world. And we have to go on a cultural journey and exploration on why we're here to do this work and figure out how do we get to workflows that, number one, give us more space in our schedule for patients. And number two, get patients who need the most care in, be able to stratify patients, and be able to monitor more. Getting that cultural mind shift to change is hard, and the quality outcomes could be better if we can get this data together to make better decisions about a care plan. I'm thankful for my dad's ability to outlive his father and so on because of modern medicine. And we can do better. We can do so much better in the care we provide for our patients every day.
I think part of the holdup is your average primary care practitioner. They've had a lot of things dumped on them, new responsibilities, but they haven't had things that create the space you're talking about. So I wonder if you could just explain, if you were talking to a primary care doctor, about how it could be different. And no, it means you could take care of more patients without making yourself even more crazy with work than you are today.
I think the best example is prior authorization. Independent primary care offices have to do this all the time. I've seen specialty care places have Excel sheets printed out that says, here's the policy for this payer, and they have workflows built to the authorizations criteria. And that prior authorization workflow can be automated. We don't need to carry around spreadsheets and memorize things and then make sure everything's in a fax. We could do that digitally in seconds by creating interoperability between places. So now the provider's office doesn't have to do the prior. The productivity rate we found when we put this type of handshake in place was 233%, it doubled.
Wow.
If we get those things into place, we're going to free up the back office time, which then is a chain of events all the way to the front end, the primary care provider, who can have real-time conversations with their patients about a plan instead of wait 2 weeks, follow up, have to recontext my brain for this patient. Okay, it's going to take context switching away from the primary care provider and enable them to have more space to be present with the patients in the office today, which creates more time because there's less context switching. It's also more actual joy in the love that we do. Instead of putting more, we're taking away and saying, hey, actually, we need you to do these more important things, which is the art of medicine. We don't need you to do prior auth or risk adjustment or check all the things on this list. What we really need you to do is be in the office, see the screen, have the orders queued up for this patient, and know if that order is authed or not in the 20-minute appointment. If we can do all that, we're eliminating a whole day. Sometimes primary cares take whole days to do their documentation and paperwork. Can you imagine just doing it in the appointment in the 20 minutes?
Yeah.
That's a full day of appointments.
But we have to get you on a national stage talking about this. Trying to convince these poor beleaguered people that are trying to do a good job with their hands tied behind their back.
It's hard to have the capacity to even think about working differently. And the financial pressures don't help because sometimes those capabilities cost more money. It's a new capability. You haven't done it before, but you're going to get rid of something else in your workflow because those capabilities are newer. It is harder to have that return on investment conversation. Tech companies are struggling with this.
Yeah.
They want to get providers to the cloud. They want this AI tool to go. And we have to think about how we price that. Maybe the tech company takes on some risk with us. We have to rethink so that we do the right thing, which is to get this tech to healthcare. Because it can't always be about, I'm going to make $1 bajillion. It's got to be about, I'm here to be the highest quality system of health. I'm here to be a national association who's going to produce a nation of high quality care.
You're giving me goosebumps, Anna.
Oh, well, this is really dear to my heart.
I love your dedication. I really do.
Well, I've been called relentless before.
That's a virtue when you're doing the right thing. Yeah.
Yes. Truly, my North Star is this can be so much better. I'm one of those silly people who stand in a grocery line or a line at the bank. I'm like, oh my gosh, we can do this so much better. Healthcare is just something that makes sense in my brain. I can re-engineer and unengineer it. And I really am thankful to be here. So thank you for saying that.
I have a question. Why is healthcare slow to adapt? I'm going to give you one of the answers, I think, and maybe ask you to comment and then ask you to think more broadly. You go to your primary care doctor and you see what it's like in those offices. See, they don't have time to breathe.
No.
And let alone stop to redesign their workflow or install this new thing. And so how do we get ourselves out of that? We're too busy to improve. When you observe a primary care practice, it is pretty crazy what people are expected to do.
The burden is heavy. The burden is heavy. I'm going to use an example that's far removed from that, but I'll bring it back. I'll circle back, and it's quality and our capability to try something new. My dad worked in medical supplies, and what you learn is it needs to be perfect because life at stake. 100%, this has to be proven. We're a 80-20 space. Like, okay, that feature is good enough. People are going to love it. And 20% are going to hate it. And we'll figure out what we'll do when we get there. Maybe healthcare is like this, but I have not seen it. We're so perfectionist. I think about quality reporting and data assassination. You present something and they're like, nope, that's wrong. That's not my outcomes. No way. Something's wrong with that.
You surely don't think I've never heard that before.
Never. I think that's wrong. That mindset of not trying something new and being an agile way of thinking, like, okay, let's get there. 80, try it. Where do we learn? Fix it 2 weeks later. Fix it 2 weeks later. Fix it. That is not something built into healthcare. And that is what we need to do in quality reporting. Is we can't get to perfection on new capabilities. There's got to be a pathway to getting there. So if we think about moving from utilizing documents that we used to trade or Excel spreadsheets or the chart chases and the boots on the ground to full digital measures, that's a big leap. And we're not going to get it right the first time.
Right.
We're not.
That's a mindset thing, right?
That is a mindset thing because I think quality has grown up in the era of this has to be perfect because they sit in these meetings and they're like, wrong, this is wrong. And so now they're like, I got to get to perfection. And that's not the truth in trying to transform. The truth in transformation is that you're going to fail a couple times or maybe a lot of times. I'll bring it back to that primary care, which is we have to figure out how we incrementally move them forward. Little by little, we have to try something new and be willing to try and fail. Oh gosh, there goes that day. It's ruined. Yes. Okay. How are we going to do it differently tomorrow? And accept that nothing is going to be perfect when it shows up on day one. And my experience in any type of technology has been that that's the expectation that we set in healthcare. As a patient, that's my expectation of my provider. And the back end might have to be a little bit of a different culture with the mindset that we must always keep people safe. And that's where humans come in. It's about enabling primary care providers to feel safe in trying something new and having that culture that it's not going to be perfect on day one. And we'll get it right. In 10 days or in a month, we'll get it right. But not day one.
Yeah, I think you're so right. The irony is, if you have this kind of perfectionist mindset and you think we can't do anything until we're sure it's going to be perfect, you're much more likely to screw things up, and you're much less likely to try to continuously improve.
You're never going to get there.
Caught in this kind of crazy situation.
Yeah. And I think the only way is to move forward is to talk about it. Let's talk about the elephant in the room and bring people along. We got to enable ourselves to bring everyone along in this journey. I don't want to shine the most. I want everyone else to shine the most, because that means I can go dream about the next thing that we want to work on.
There's a lot of profound things that you're saying, Anna, always. Why don't you tell us about MultiCare's project called Fire Forward?
Yes. As a part of this journey to get better, speaking of that mindset, we figured out how we could try this. We're part of a financial model, Medicare Shared Savings Program. That model requires you to report quality. They gave us 4 methodologies, which was web interface that gives you a list of 11 measures, and it's sampling, traditional quality reporting, where you get us 250 people, you work down a list, you get their data. We query for all that information, and then we fill in the blanks with labor. The second methodology is eCQM. eCQM is a type of digital quality measures. We get this big document and we squish it all together to get the result, and we report it back to CMS. In that work, you have to deduplicate patients, you have to aggregate from multiple EMRs, and you have to get to a full aggregated report. The third methodology is MIPS CQM, which you can add extra stuff to. You could add the labor and the chart chasing, et cetera, to that methodology. And then there's digital quality measures, which is called Medicare CQMs, clinical quality measure. That methodology enabled us to report using an API, application protocol interface, also known as trading data over the internet, which healthcare traditionally does not do. It trades in private VPN tunnels. In the API world, you get to trade data in a secure manner, and you can do it more discreetly than in a full document. If you think about it as a piece of paper you're trading electronically, this is, I need first name, last name, and that's all I need. I don't want any of this other stuff in this big giant document. So we chose to report using APIs, and we grabbed all the quality data that we needed to report for Medicare Shared Savings Program. We compared web interface, old school sampling, to new school API. My hypothesis was we were going to be way off because we had never done this before. We don't know the quality of data in these APIs and how the data is mapped from the EMR to these things that are trading outside. And turns out, not so bad. Actually, pretty good. Like maybe 70% there, which gives me goosebumps that we can go from doing just a sample, 250 people, to 12,000 people who qualify for measures. We can say, hey, how are you performing on that population on your A1C? Well, we came within a 5% delta. So our web interface result was 5% off the API result. We reported 2 other measures. Depression screening and follow-up was in the high 20%. And then blood pressure control was in the lower 20% range in the delta. That makes me really excited because I thought depression was going to be a 50% or 60% delta, and it wasn't. That says to me, using the internet for healthcare and the mappings to these discrete data elements are so strong that we can start working towards closing that gap. We could probably get within 1%. Deviation, I'm going to deviate 1 to 3% across all 4 of those choices. So we're almost there with one measure, and we could get really close with the others. We just need to start peeling back the onion of, okay, is it the mapping? Is it that we don't collect this data? Is it that the workflow isn't working for the provider, so it's not collecting the data in the way we need it? There's lots of ways to mature our workflow to get better at those things, but we're closer than we think. This isn't a lot of work. This is close. And hey, we're going to do it for 50,000 people, which is even more incredible. And the cost is under $1 for a life to report this measure. I think that the future is bright to be able to achieve these things.
You can tell you're the daughter of an engineer because you approach this big tangled mess.
This is tangled.
You figure out a way to kind of drill into it or pull out one piece at a time. And it leads you to thinking about a way of designing it in the first place so you don't get the tangle. You're a natural storyteller. You need to be telling the story because I think you tell it in a motivating way, in a way that it's possible to succeed. I think people are afraid of, if I step into this, I'm going to fail. And this idea of don't expect perfection, do what you can, but we're going to be changing this as we learn. That mindset is crucial.
That's the new mindset for all of us. If we can start at quality touches everything. And it gets results for everyone in the ecosystem. Gets a win-win-win. Not all the use cases have that.
Yeah.
That's why I kept pushing back to quality. They're like, rev cycle. I'm like, but quality. Because the story is better.
Yeah.
And people understand it. And that can translate into these other use cases.
Yeah.
We got to pick a use case where everybody can consume it as a human, understand, and start forward.
Like kind of virtue with its own reward in this kind of thing, right?
Yes.
Because it really creates the feedback loop that makes people be able to continue to go at it.
Yeah, that's right.
Yeah. It's so impressive, Anna. And I just want to thank you for everything you're doing for American healthcare. I think we're out of time. I could go on and on with you, but thank you for everything. I really appreciate the time.
Thank you so much. That is an absolute honor, and it's a privilege to have the capability to do it.
Thank you. As I reflect on my conversation with Anna Taylor, I'm struck by her clarity, conviction, and relentless optimism. Anna doesn't just talk about transforming healthcare. She engineers that transformation. Her ability to dissect complexity and reimagine systems is matched by her empathy for patients and the people who deliver care. What she describes as more than technical innovation, it's cultural leadership. She reminds us that perfectionism can be a barrier to progress and that embracing imperfection is essential for improvement. And for interoperability, value-based care, and digital quality measures isn't just aspirational. It's practical and it's achievable. And it's rooted in the certainty that we can do better. And one of the things I really appreciate about Anna is that she takes words like interoperability and makes us all want to have more of it. I'm proud to call her an ally in this movement to make healthcare not just better, but excellent. I'm happy to know smart, dedicated people like Anna are here to continue the quest for quality and value. I hope you got as much out of this conversation as I did.
Thank you for joining us this time on Quality Talks. If you enjoyed this podcast, please rate us 5 stars wherever you listen. We'll see you again next time.